TopMed Talk.
TopMed Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Last-minute tickets for EBPOM Ireland 2026 are available. Taking place from the 29th of September through to the 1st of October in the beautiful town of Dingle, Ireland, it's your chance to join us for an inspiring gathering of healthcare professionals, researchers and educators dedicated to advancing evidence-based practice through engaging keynote sessions and international collaboration. Check out ebpom.org. That's ebpom.org.
So our first session today is on global perspectives of postoperative care. Nicolai Bang-Foss is the head of GI and orthopaedic anaesthesia at the Hvidovre University Hospital in Denmark. His research focuses in particular on perioperative care of the elderly emergency patient, optimizing care following emergency abdominal surgery and hip fracture surgery.
Well, thank you for inviting me, and thank you for the introduction. I've been working the majority of my career at Hvidovre Hospital. That's sort of a cognitive test to pronounce for non-Danes. And I've worked with both emergency surgery and the elderly. If you don't know Hvidovre Hospital, that's actually the birthplace of ERAS. The first part of my career was together with Henrik Kiele trying to implement the ERAS concepts, and all the original ERAS studies were done there. It's a regional hospital catering to a population of around 800,000. I was given the task to give an overview of Europe, which is completely impossible because there's no standards, there's no single way to do it in Europe. Just look at the different ways we pronounce 92. Various ways of doing it, and obviously the Danes, due to the small size and massive inferiority complex, tend to complicate things. But I tried to get an overview. My experience is from Denmark, and that's what I can tell you the most about. But there are no standards. How do you do postoperative care? How do you do PACU in Europe? It varies from country to country. There's no uniform standard. And I think the main thing to look at here for the variation is a variation in number of ICU beds. You've just had some numbers. Australia was at 9 per 100,000, the US around 20. Look, Germany, we have, 30 ICU beds per 100,000. And then we have down at the bottom, the Scandinavian countries are extremely lean on ICU capacity. Denmark is 6. That means very low ICU capacity, and that dictates the different pathways and how people tend to do things. Because what we have in postoperative care with the tiers, we have our PACU, and historically a PACU was a short stay unit. You went in there for a few hours, then to the surgical ward. Otherwise, if you're big and prestigious surgery, transplants, liver surgery, went directly to the ICU. Traditionally, emergency surgery, PACU off to the surgical ward. Let's see how it goes. But the PACU unit is nursing staffed, anesthesia-led. Usually, and it isn't standardized in Europe either, but the European Society of Anesthesia recommends criteria-based discharge, usually something like the Aldrich score or the modified Aldrich score, which is based on physiological criteria, motor block, etc. Traditionally, a lot of PACUs have closed overnight based on elective and getting the patient out there and then transferred to ICU. In Denmark, it varies completely. Some centers still have short PACU, takes to the ICU at night. Some centers have PACUs that are 24 hours. And there we drift into the intermediate care, which is also not standardized in Europe. Some centers, it's similar to enhanced post-operative recovery units, but you can, in some centers, stay there for 24 to 72 hours, have better nursing ratio than wards, but not like the critical care unit. And usually it's like the tube and the ventilator that makes a difference. And when I started anesthesia in Denmark, you didn't go to an ICU if you didn't have a tube, right? Otherwise, it's the ward. And that has changed over the years. But some departments have localized surgical IMC, surgical driven. specialized. In Germany and France, they have a lot of IMC. They call it different things, but they can either go pathway that said PACU, ICU, IMC, or other forms of step down. And obviously, as dedicated kinds of surgery and multi-organ failure, go to the ICU. But generally, it's not standardized, and there are a lot of different pathways. The national differences with Germany, Austria, Switzerland, the highest critical bed capacities in Europe. So there's a very liberal ICU admission. If you're high risk or intermediate risk, you can go to ICU, you can go to IMC. France actually have a legally codified system on what's needed. In Scandinavian countries, it's just the society is doing some recommendations on how you do it. So in the Netherlands and Nordic, we have very lean ICU capacity. That means that basically the PACUs have evolved into most centers 24-hour units that does more and more, especially with high-risk patients. And another thing, we haven't touched a lot about that. I think it's really interesting that there isn't any standards for what constitutes a PACU nurse. There isn't specialized educations in many countries, besides, as I understand, Ireland and the Netherlands, which have a standardized education. And we've just started one in Denmark, but it isn't mandatory. Otherwise, PACU nurses tend to be either specialty nurses from surgical wards and sometimes ICU nurses. But in Denmark, it's usually the pre-step to doing anesthesia nurse or ICU nurse. So it's sort of intermediary between surgical ward nurse and going on to anesthesia nurse. And PACUs in Denmark are anesthetic-led. And what we've seen over the last 25 years is, I would say, a development from what we call the traditional PACU, which was focused on postoperative care, getting the patient to the surgical ward early. And originally it was mobilization in the surgical ward, and more it's now mobilization already in the PACU as the main driver. And I think that's the difference between a lot of IMC, ICU units as we see it. They focus on organ failure, and PACU focuses on the ERAS principles of mobilizing patients, getting the flow on. But with the focus on high-risk emergency surgery, originally with our hip fractures, we moved more and more into the perioperative unit, we call it, where we take patients preoperatively to the PACU or perioperative unit for optimization. We put in blocks, epidurals for hip fractures, do hemodynamic optimization. And this was also what we started when we started Sirut in Denmark, similar to the NILA in the UK for emergency laparotomy. The PACU was the place where patients got taken before surgery for optimization, awaiting surgery, putting in lines, and the surgeons come and do the final diagnosis in the PACU or perioperative unit. And also, not in the ICU, but the majority of emergency surgery actually goes to the PACU or perioperative units for 24-hour stay afterwards. It doesn't really involve the ICU. And in Denmark, there's sort of an ICU as a tradition of not doing the enhanced recovery stuff. It's you lie in bed and you're really sick, but if you're going to get mobilized, you go to the perioperative units. But what happened with that, when we did our original cohorts, we reduced intensive care stay massively by introducing the NILA concept. I would say before, it was around 25% of ICU capacity in Denmark was emergency laparotomy. Patients were lying there. And just at my hospital, the first 2 years, we cut out 600 ICU days just by optimizing emergency laparotomy care. And we have the patients in the PACU. But obviously, that conflicts with the flow of elective surgery that also goes through the same units. And that has been sort of, we haven't had resources extra for that. So we have been looking how to further optimize short-term stay, what I call the, tea and crackers patients, as opposed to the real sick patients, those that are waiting just to get to the ward. And one of the things we looked at years ago with our total hip and knee replacements, which is they're big production units. They take in a lot of patients. They go through the PACU. We saw that a lot of these patients, if they have undergone spinal anesthesia, they come to the PACU, and they actually, if you take away motor block, they're discharged ready like in 15, 20 minutes. So motor block is the main driver. And my colleague Lund did together with Esgårdsvang and RCT, where they said, can we take them from PACU to ward without looking at motor block? and there was no change in complications. And that, over the years, simply led to an adaptation when we started the NILA, or what we call acute high-risk abdominal surgery care, that we said, well, we need to get rid of all these patients in PACU to make room. So we made a bypass PACU concept for our electives, hips and knees, and documented it, published in Anesthesia, where we could say more than half of our total hips and knees went directly to the ward, bypassing PACU. And the criteria for that they had to go to PACU if they were ACE3 or more, or 500 milliliters or more of bleeding, or if they had undergone general anesthesia. But spinal anesthesia, uncomplicated, just bypass PACU. And there were no extra resource use or complications in the ward after that. So I think we're sort of seeing the PACU or perioperative unit is sort of differentiating into more emergency, high risk, longer stay, and bypassing simple things. How can we make it lean and make them just bypass the PACU? Because that's usually not where the issue is. They often go home in the night or the next morning. So that's I think that's where we in Denmark are going, and it's different for the different countries. One thing, it's interesting, I had a PACU nurse, a PhD, looking at discharge criteria from PACUs, and there's so little knowledge about it. There's so little actually objective or evidence-based criteria. When can you be discharged from a PACU? Where should you go? And we make this study. This is coming out of the EJA. I think it's a bit funny, actually, because we had high-risk patients, not with a planned long PACU stay, but discharged by PACU criteria. And then in two separate hospitals, we had the PACU nurses that did the modified Aldrich score, they did a modified EVS score as well. And then they also said, do I think, from my professional opinion, that this patient will be stable in the next 48 hours, or will this patient give problems in the ward? So basically their professional gut feeling. And that was just significantly better than any of our scores. And basically our scores doesn't predict anything. So I think this is the rock curves for nurse assessment versus the scores that are basically useless. And I think it's an area, how long you stay in PACU, when we take the patients further on, and how we do it, how we assess it, that's an area that needs a lot of research, because it's actually, even the short stays are quite resource heavy. And a lot of patients don't need it, and we still don't, like failure to rescue. We're not really that good at identifying the patients that actually need more, like whether you call it IMC or perioperative unit or EBPOM or whatever. It's all the same thing. Intermediate care or longer, more enhanced observation. A final word, I think our real challenge is the surgical wards. In space, nobody can hear you scream. They have continuously been cut in nursing staff. And we see more and more that senior and experienced nurses, they go to specialized units. So like the average bread and butter surgical orthopedic GI units, especially the orthopedic units, usually have the least experienced nurses and sometimes the lowest staff. And one of my colleagues who works specifically with PACU says, we don't have a step-down system, we have a fall-down system. So once you leave the PACU, IMC, you go to a place, rather it's like going from something that's Uber plus black to an old Trabant from the Eastern Europe. And it's a real issue. We have a huge gap there, and surgical observation in the wards are often not sufficient. And I can hear from other countries that post-COVID, this has been exacerbated. We had a specialized hip fracture unit with specialized nursing staff gone after COVID with just patching things up to make nursing staff take care of these patients. And I think that's a big issue, and it puts extra pressure on the triage from the PACU into the surgical wards, because the less experience and professionalism in the surgical wards, the more we need the PACU and the intermediate wards. And we're actually now doing, our med team specifically goes to our hip fracture unit every day to assist the younger nurses and trying to help them with hip fractures, and that caused mortality to go back again after rising. So I think with this crisis of staff, we're looking into different ways of doing things, even leaner in the lean system. Thank you.
Top Med Talk.
Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Last-minute tickets for EBPOM Ireland 2026 are available. Taking place from the 29th of September through to the 1st of October in the beautiful town of Dingle, Ireland, it's your chance to join us for an inspiring gathering of healthcare professionals, researchers and educators dedicated to advancing evidence-based practice through engaging keynote sessions and international collaboration. Check out ebpom.org. That's ebpom.org.